welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, we're going to have Zoey Chasen. She's a PGY2 critical care pharmacy resident at the University of Iowa Healthcare. And today she'll be presenting on the association between receipt of ketamine versus etomidate for emergency tracheal intubation and symptoms of post-traumatic stress disorder at 12 months.
Like they said, I will be presenting on the association between receipt of ketamine versus etomidate for emergency tracheal intubation and symptoms of post-traumatic stress disorder, or PTSD, at 12 months. This was published in Chest Critical Care in January of 2025. The objectives today are to review the epidemiology and pathophysiology of PTSD, or post-traumatic stress disorder, summarize the role of etomidate and ketamine in emergency tracheal induction, and also they may play a role in PTSD, and then evaluate primary literature more in depth regarding the association of etomidate and ketamine with PTSD. We'll first start off with a little bit of background about PTSD and how the ICU may play a role in this. ICU-induced post-traumatic stress disorder is not uncommon. Unfortunately, about 34% of ICU survivors will go on to experience post-traumatic stress disorder symptoms from their time in the emergency department and in the ICU. This can persist for years after their stay and can negatively impact their well-being, quality of life, and employability. A lot of this stems from memories of frightening and distressing experiences that they may have while in the intensive care unit, including delusions and hallucinations, as well as sleep. This contributes to and increases their risk for developing these symptoms, especially for patients that receive particularly traumatic interventions such as mechanical ventilation. Additionally, about a quarter of ICU survivors will go on to develop long-term cognitive impairment that further affects their morbidity. This can be similar in severity to a mild Alzheimer's. Emergency tracheal intubation is one of the many things that may be linked to the development of PTSD and anxiety and depression after an ICU stay. Over 2 million adults annually in the United States alone require emergency tracheal intubation due to critical illness. Sedation improves the intubation conditions and therefore increases the chance of first-pass success. Patients still may be under-sedated or may have multiple attempts at intubating them, which can further increase the rates of these unpleasant consequences. The most common sedatives used for this purpose are etomidate and ketamine, as well as some other agents, but these two will be the focus of our discussion today. Etomidate is an ultra-short-acting, non-barbiturate hypnotic anesthetic agent that is overall the most commonly used agent for this purpose. It's used in about 90% of cases due to its easy access and desirable characteristics. Some of its benefits include the fact that it's inexpensive and readily available. Given that it's not a controlled substance, it's very easy from a storage perspective and is able to be obtained quickly, whereas some other agents that are used for induction may be instances where there has to be more documentation or countbacks to a medication, taking more time in the setting of true emergencies. Additionally, it has a rapid onset of action, which is desirable in the setting of an emergency tracheal intubation, as you want to get this agent on board quickly so you can proceed with intubation quickly. Additionally, its short duration is useful as when paired with a short-acting neuromuscular blocking agent, it will wear off about the same time, and you can then more lightly sedate patients or conduct neuro exams. Additionally, it has a predictable dose-related response and is overall hemodynamically neutral, which is favorable in patients may be very hemodynamically unstable. On the other hand, there are some potential concerns when considering etomidate, and a lot of these may be controversial, and we're not exactly sure how they truly patients, but these concerns do relate to clinical implications on adrenal suppression, especially in the setting of conditions such as sepsis or adrenal insufficiency in general. And it can also potentially have effects on the seizure threshold. But again, these may be clinically unclear how much we truly care in our patient populations. On the other hand, ketamine is a non-barbiturate phencyclidine derivative that decreases the activity of glutamate. While ketamine also has some similar benefits, such as its fast onset and shorter duration of action, it does have additional benefits that may make it a better agent for certain patient populations. For example, it has analgesic properties, so if your patient has a lot of pain, such as in the setting of a polytrauma, it may be a great agent for that case. Additionally, it's the agent of choice for reactive airway disease, so if patients have a history of this, it may be another time to utilize it. On the other hand, ketamine does have some additional concerns. First, it's a controlled substance, so as I alluded to before, it may take a little bit more time to obtain in the setting of a true emergency. So if you don't have an extra minute or two to obtain the supplies, it may not be worth some of those other benefits. Additionally, like Etomidate, it has some maybe controversial potential concerns, such as its effects in catecholamine-depleted patients and the risk of hypotension, as well as questionable effects on intracranial and intraocular pressure. The studies I'll focus on here for the sake of time really narrow in on Etomidate versus ketamine, although there's been numerous studies comparing them to other agents for intubation as well. The first study by Upchurch and colleagues in 2017, which was a retrospective evaluation of 968 adult trauma patients. They ultimately found that ketamine and Etomidate were safe and effective with no difference in mortality, ICU-free days, or ventilator-free days. In 2017, Van Berkel and colleagues conducted a retrospective propensity-matched cohort study of 384 adult medical intensive care unit patients. They found that Etomidate increased rates of hypotension compared to ketamine. However, other studies have shown a little bit different results, such as the Kroll and colleagues and Moore and colleagues in 2020. These two studies looked at adult emergency department patients, totaling over 7,000 as their sample size. Both studies showed that consistently ketamine increased hypotension when compared to Etomidate. And finally, Matchett and colleagues in 2021 conducted a randomized labeled trial of 800 adult patients. They found that ketamine increased day 7 survival. However, when they looked at longer-term outcomes of 28-day survival, there was no difference. And all of these studies showed that they're both potentially appropriate agents for a lot of patients. Knowing that these agents are both safe and effective, we really have to figure out what patient-specific populations these are going to be appropriate in. Ketamine is utilized in the outpatient setting for PTSD, so it has been theorized that maybe it could be useful in preventing PTSD in settings where it may be traumatic, such as intubation. Ketamine helps reduce the development of PTSD symptoms by inhibiting the brain's glutamatergic system. This system normally mediates stress responsivity and resiliency and plays a role in the PTSD development. By giving ketamine, we are unable to be stimulated by glutamate, which then blocks downstream pathways which form the distressing memories from critical illness, intubation, and mechanical ventilation. There are some studies looking at how ketamine affects PTSD, and while these are a really different population than the study we'll focus on today, I still think it's important to present them as they are a little bit of background and why we would maybe investigate this. Looking at these studies, the differences I want to highlight first are that these are for chronic PTSD, so they're not for acute PTSD from a quick occurrence such as this intubation, patients that came in with a history of PTSD. They're also for treatment, whereas these are to provide long-term treatment in the outpatient setting. Nevertheless, I think it's important to focus on them, and the first was by Fetter and colleagues in 2014. They conducted a randomized crossover trial of 41 patients with chronic post-traumatic stress disorder. Patients were given a single infusion of ketamine, 0.5 milligrams per kilogram versus midazolam, and found that ketamine decreased PTSD symptoms at 24 hours. Later, Fetter and colleagues also conducted a randomized trial on 30 chronic PTSD patients. With this, they gave patients 6 infusions of either ketamine or midazolam over a 2-week period of time, and when assessing symptoms at that 2-week mark, they found that ketamine had decreased PTSD symptoms statistically significantly. However, the guidelines really don't comment on the use of these agents to potentially help with PTSD or other occurrences in the intensive care unit. They really give more of blanket statements such as advising administering a sedative hypnotic induction agent, which ketamine or Etomidate would fall into, whenever a neuromuscular blocking agent is used for intubation. Additionally, they state that there's no difference between Etomidate or other induction agents that are administered for rapid sequence intubation with respect to mortality or the incidence of hypotension or vasopressor use. With this, you really have to target your agent to patient-specific characteristics and also provider comfortability. This leads us to the purpose of this study, which is really to try and find a potential niche for ketamine by comparing the rates of PTSD in patients who received Etomidate versus ketamine for emergency tracheal intubation. We'll next talk a little bit more about the methods of the study that we'll talk more about in depth. This was a secondary analysis of a pragmatic cluster randomized crossover trial. It looked at the pilot and co-pilot studies. These were studies that originally investigated the effects of different oxygenation targets in patients that were receiving invasive mechanical ventilation. Patients were initially enrolled in this trial between July 1st, 2018 to August 31st, 2021. However, they then received funding for a 12-month psychological outcomes assessment that would be assessed, again, that 1 month after their stay, which was received from January 1st, 2019 to August 31st, 2021. Patients were included in the original trial if they were ages 18 years or older and received invasive mechanical ventilation in the Vanderbilt University Medical Center Medical ICU. They were excluded if they were incarcerated, pregnant, did not have a completed 12-month follow-up, which could be for a variety of reasons, including not speaking English, not having access via the phone, or having severe aphasia or other disabilities. And they also excluded patients that were previously enrolled. In addition to these criteria from the pilot and co-pilot study, the study added 3 more as seen here in red. Again, they excluded patients if they did not specifically have that 12-month psychologic assessment, even if they did have an overall follow-up visit. They also excluded patients if they did not receive ketamine or etomidate for induction of intubation, or if their intubation procedure was not clearly documented. The interventions in this study were IV ketamine versus IV etomidate. Given that this was a retrospective study, both the agent selection and dosing were based on physician preference. No specific doses were reported for either agent, but the authors did state that most doses were based on the US FDA recommended doses of 1 to 2 milligrams per kilogram for ketamine or 0.3 milligrams per kilogram of etomidate. The primary outcome in this study was symptoms of PTSD at 12 months. This was assessed using the PTSD checklist or PCL5 from the DSM-5, which is shown here on the right. This is essentially a set of 20 questions that assess how much a patient has been bothered by different symptoms over the past month. Patients rate these and ultimately get a score from 0, which is no symptoms, all the way up to 80, which is severe symptoms. A cutoff of 31 or higher indicates symptoms of PTSD. Of note, the authors chose an endpoint of symptoms of PTSD rather than a formal diagnosis for 2 main reasons. First, this would increase their power, but also patients may have these symptoms without that formal official diagnosis, and it can still be really troublesome for them, can really affect their morbidity and quality of life. So while they don't have that formal diagnosis, it's still a meaningful thing to change. Secondary outcomes were also assessed at 12 months for each of these. The first 2, depression and anxiety, were assessed on the subsection of the hospital anxiety and depression scale. These range from 0, which is symptoms, all the way up to 21, which is severe symptoms. And again, a cutoff of 8 or higher is indicative of depression or anxiety for each of these. Additionally, they looked at global cognition and how this was impacted using the Montreal Cognitive Assessment Blind or MoCA blind scale. This is a scale that has patients their memory, attention, language, abstraction, delayed recall, and orientation. Unlike the other scales I've previously presented, it's inverse as far as a scoring perspective. So 0 represents worse outcomes with fully impaired cognition, and the maximum score of 22 shows fully intact cognition. A cutoff of 18 here is where they marked having global cognition impairment. For statistical analysis, all of their outcome assessments were conducted by trained neuropsychological raters who were blinded by intervention that patients received. They also conducted this solely via phone. Analysis was conducted using proportional odds logistic regression, and they utilized this due to non-parametric data distribution. They also calculated adjusted odds ratios with a 95% confidence interval and a p-value of 0.05 or less being significant. They adjusted for many covariants, which were pre-specified, including age, race, sex, number of comorbidities, which included chronic obstructive pulmonary disease, end-stage renal disease, congestive heart failure, and coronary artery disease, as well as history of pre-illness depression or post-traumatic stress disorder, years of education, non-respiratory SOFA score, sepsis, and location of intubation. They also conducted post-hoc exploratory analysis using multivariable logistic regression to see if there were any indicators of how ketamine versus etomidate affected their various endpoints. Moving into the results section of this study, overall 2,541 patients were enrolled in the pilot study. 1,677 were enrolled when they had that psychologic assessment funding period. 1,515 of these patients had co-pilot enrollment. Only 583 patients ultimately survived that 12-month follow-up visit, but only 297 of these patients actually had that 12-month PTSD assessment conducted. Additionally, a lot of patients did not receive etomidate or ketamine as their agent for induction, or it was not fully documented. So this left with a final sample size of 141 patients included in the analysis. Looking at the baseline characteristics, 52 patients received ketamine versus 89 in the Etomidate group. On average, patients were in their mid to late 50s, and about 40 to 45% were female. The vast majority of patients were white and not Hispanic, although there was a 10 to 15% of patients that were Black as well. On average, patients had 13 years of education in the ketamine group versus 14 years of education in the Etomidate group. Looking at some of their baseline disease states, no patients had a history of dementia. About 17 to 18% of patients had a history of post-traumatic stress disorder, and about 43% of patients had a history of depression. Looking at the number of pre-illness comorbidities, again, that just focused on COPD, end-stage renal disease, heart failure, and coronary artery disease, on average, patients really didn't have any of these comorbidities and only had a non-respiratory SOFA score of 4 in the ketamine group versus 5 in the Etomidate group. Additionally, about 19% of patients had sepsis in the ketamine group versus 27% in the Etomidate group. The other area that really differed between groups was where they were intubated. In the ketamine group, the vast majority were intubated in the emergency department at Vanderbilt, whereas in Etomidate group, only about half of them were intubated there, and about a quarter were in the outside hospital. Looking at the primary endpoint, the PCL-5 score, on average, patients in the ketamine group had a score of 7 versus 14 in the Etomidate group. When you specifically pull out patients that reached that score of 31 or higher, you saw occurred in 15.4% of patients that received ketamine versus 20.2% of patients that received Etomidate. And this was statistically significant, showing an association of less PTSD symptoms when patients were given ketamine. Looking at the HADS depression score, on average, patients in both groups had a score of 5. And when you pulled out that cutoff 8 or higher, we saw it happen in about 34.6 or 34.8% of patients based on which agent they received. This was not statistically significant between groups. Anxiety, on the other hand, had an average score of 5 for the ketamine group and 7 for the Etomidate group. But again, we saw no difference once we got that cutoff of 8 or higher, where we saw 36.5% in the ketamine group and 46.1% in the Etomidate group. Again, the anxiety score was not statistically different between groups. And finally, looking at the MoCA blind, just to orient you a little bit. So as a reminder, this is inverse, where higher scores are actually indicative of better outcomes. They use the inverse of odd ratios just to keep the directionality consistent between all of the endpoints. Looking at the overall score, on average, patients that received ketamine had a score of 18 versus 17 for patients that received Etomidate. However, when they pull out that group that was below that cutoff of 18, they saw global cognition impairment in 44.2% of patients that received ketamine versus 61.8% of patients that received Etomidate. And this was statistically significant association of global cognition impairment with Etomidate. Looking at their post-hoc exploratory analysis, they really didn't find any endpoints where there was any specific association of ketamine or Etomidate with the endpoint based on different variables they utilized. Moving into the discussion portion of this journal club, the authors ultimately concluded that ketamine has an association with fewer PTSD symptoms and better global cognition at 12 months, but no difference in anxiety or depression when compared to Etomidate for emergency tracheal intubation. However, they also concede that larger prospective trials are really needed to confirm these findings. As far as my personal takeaways, I do want to highlight some of the strengths that the study had, as I think they were overall meaningful. I think one of the things to point out here is their inclusion and exclusion criteria. And while I'll maybe comment a little bit on sample size and the weaknesses, I think they did a really good job narrowing it down. They obviously weren't able to control what the previous study had included or excluded, but the only additions they made were really what they truly had to add in order to narrow in on the population they wanted, whether it was patients that actually had that assessment conducted so they could evaluate their endpoints or focusing on their specific agents. The other strength that I think is maybe most special about this study is the fact that they used long-term patient-centered endpoints. I feel like it's pretty rare, especially in an ED or an ICU study, to not only get patient-centered endpoints, but long-term endpoints all the way out at a year. I think this is really meaningful, as we know that maybe these won't affect our chance of survival at 1 year, but ultimately we may see more of an effect on quality of life and morbidity, which is stuff that patients truly do care about. I will comment on this in the weaknesses as well. I think in general, they had meaningful covariate adjustments. They really touched on some of those places where they did have differences between groups, such as location of intubation, but they also got covariates that would be meaningful, such as history of pre-illness, PTSD, anxiety, depression, etc. I do think there are significant weaknesses that limit our ability to apply this study to clinical practice. First of all, it's retrospective, and that's going to have inherent issues with it. Ideally, a prospective randomized controlled double-blind trial would have been preferred. And additionally, it's secondary analysis of a study, which has its own implicit issues as well, including a higher rate of a type 1 error. Another weakness is the sample size. And again, I kind of concede that the inclusion and exclusion criteria really couldn't have been more broad, but ultimately we really had a small population included when we looked at the overall study originally. The only way they really could have improved this was by increasing that funding period, but obviously that wasn't something that was necessarily in their control, but something to look at moving forward. One of the weaknesses that I thought was interesting is that overall these patients have a low level of disease severity. When you think about the fact that these patients have to survive not only their ICU stay, but all the way out a year, it makes sense that they wouldn't have super high SOFA scores. Not a lot of the patients would have sepsis. But I think it could have potentially been remedied a little bit if they had maybe done some secondary analysis where they stratified by disease severity levels and looked at if this applied to just patients with lower disease severity, higher disease severity, or both. Additionally, I think there's a lot of confounders in the study that aren't accounted for, even though we do have some of those adjustments. The biggest one to me is why these specific agents were chosen for induction. For example, was ketamine chosen for its analgesic properties in certain patients as maybe they had polytrauma or other things where they may have had a lot of pain? On the other hand, was Etomidate chosen because this intubation was a true emergency where maybe they really needed to get the patient intubated as soon as humanly possible and they didn't have that extra minute or two to grab ketamine? Some other issues for me are they didn't report a lot of information that I think would have been helpful for dosing of these agents. They gave that blanket statement that they generally followed the FDA recommended guidelines, but I know I've seen in clinical practice that we don't always follow that, and I've definitely seen patients overdosed. With this, there's a concern that maybe they're not fully sedated and maybe a little bit aware during their intubation. So even if we didn't have like an average dose, at least seeing what percentage of patients fell outside of that. They also didn't report rates of first pass success, and I think that could definitely matter, especially if patients in one group had a higher rate of first pass success than the other, because again, the more and more attempts it's going to take to get into someone, the more and more traumatic that's going to be, and the higher risk of them having their sedation wear off during this intubation procedure. Additionally, the ICU and hospital length of stay were not reported, and I think this is meaningful for two reasons. First of all, longer lengths of stay are going to be associated with more deconditioning, higher rates of delirium, and other negative effects that could definitely impact our patients. So again, if one group had a much longer stay, I think that would be meaningful. Additionally, when we look at how ketamine is utilized for PTSD, I think this definitely plays a role. In general, in the outpatient setting, and again, this is kind of extrapolating a little bit, we give that dosing every 2 weeks. So theoretically, if patients were in the ICU or the hospital for longer than 2 weeks, I think it's really hard to account that maybe this induction dose truly affected it for that full length of time. And finally, they didn't report any safety outcomes. I don't think this is a huge weakness given that we do have a lot of studies already looking at this, but I do think it would have been a nice addition to the study and also just something to the body of literature that already exists. So my personal conclusion is ultimately that larger prospective studies really need to be conducted prior to implementation or changing practice. I definitely think this is an interesting study and something that maybe could provide some information and some framework for some changes in the future, but I don't think we have enough information, especially given the limitations, to change practice right now. I would continue selecting my induction agent based on access and patient-specific characteristics. So for example, again, if it's a true emergency, you need the agent immediately, I would lean toward Etomidate because that's a lot quicker to access at my institution. On the other hand, if patients had convincing reasons to get ketamine, such as reactive airway disease, I would lean more towards ketamine, but I think a lot of this is going to continue to be based on provider preference as well. With that, I'm happy to answer any questions anybody may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice diagnosis, or treatment, and the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.